My name is Aleš Linhart. I'm working as a cardiologist in Prague, Czech Republic, running a center that hosts the major center for Fabry disease in the Czech Republic. Since many years, we are taking care of those patients, and as now we are treating more than 250 patients with Fabry disease, basically the entire cohort that was detected in our country. It's an X-linked disease, so females are generally less affected than males. It's a progressive disease and it has different manifestations. And we know that the classical disease is a severe disease that starts really in childhood, especially in affected boys, with exercise intolerance due to a lack of sweating, due to abdominal pain and diarrhea, due to peripheral neuropathy that's manifesting with very painful crisis, sometimes accompanied with elevated body temperature. But what's killing our patients is a deadly trial consisting of cardiomyopathy that usually starts in the third or fourth decade of life, renal involvement progressing from microalbuminuria to proteinuria and end-stage renal disease in fourth or fifth decade in males, but sometimes even earlier. And patients may get a stroke, and the stroke of different severity, and some of them are even hemorrhagic, can be sometimes really debilitating and shortening the lifespan of our patients. The life expectancy of untreated males is usually 20 years shorter as compared to the general population. Females are losing an average 5 years of their lives. However, we realized that over the last 2 decades, a lot of variants that are associated with Fabry disease emerged. So those mutations sometimes are relatively benign, associated with mild disease, appearing quite later during the life of patients. And those so-called later onset manifestations or later onset variants are very often just characterized by cardiac involvement, and sometimes they are being mistook for hypertrophic cardiomyopathy. We also learned that some variants are rather benign, or they are maybe polymorphisms, and we should be very cautious interpreting the genetic result and not labeling all patients as having clinically relevant Fabry disease. For this, we have different means how to classify those patients, not only the clinical manifestations, but also the residual enzyme activity and lyso-Gb3, which is the most important biomarker we are using today. So the trouble with Fabry disease is that we have different variables that are acting in the disease classification and progression. So the first one is age. As patients are aging, the accumulation of the substrate, which is global ceramide, and accumulation also of the toxic lyso-Gb3, deacylated global ceramide, are impacting on different organs. So we have the path, for example, very well described in cardiac disease. So it starts with benign changes like subtle ECG changes, but then left ventricular hypertrophy appears. There are probably some areas that are getting inflamed, they are edematous, and the development of fibrosis is a sequelae of this process. And patients are getting arrhythmias, they are getting heart failure, and they may ultimately die of cardiac disease, which is of today the most important cause of death in Fabry disease patients. So we should keep in mind that any organ system that's involved is following the same pathway. So we need a panel of evaluation of our patients. For the kidney, we are monitoring albuminuria, we are measuring estimated glomerular filtration rate, but a lot of patients are undergoing kidney biopsy, especially those with variants of unknown significance. For peripheral neuropathy, it's very difficult sometimes to get an exact depiction of the character of the disease. Lack of sweating should be sometimes measured. Patients are undergoing MRIs of their brains because they may develop white matter lesions, they may develop sequelae of strokes as well. We are, of course, examining the skin because Fabry disease was first described as cutaneous disease, so angiokeratomas are very important. In some patients, they are representing a major clinical trouble of our patients. And of course, cardiac disease, which needs a multiple investigation with using just ECG, Holter monitorings, echocardiography, cardiac MRI, and biomarkers. And to sum it up, we need some integrative approach, and we are using multi-organ scoring system, like, for example, mind severity scoring system. We are using questionnaires to appreciate the quality of life of our patients. And last but not least, we are also using biomarkers, in particular lyso-Gb3, not only for diagnosing the disease, but also for monitoring the outcomes of the therapy. As for now, we have quite a large choice of therapies. It started with enzyme replacement therapy with agalsidase alpha and beta, and quite recently with pegadigalsidase alpha is available. Agalsidase beta and alpha are approved both in the United States and in Europe. Agalsidase alpha is generally approved elsewhere, but not in the United States. So those three enzymes are given intravenously. They are given every second week at different doses. Agalsidase beta and alpha, pegadigalsidase alpha are given at 1 milligram per kilogram per body weight. Agalsidase alpha at 0.2 milligrams per kilo. But the important rule is that every second week, the patient should have the infusion of the enzyme. And the idea is that this infusion of the enzyme is getting the enzyme in touch with cells. The enzyme is uptaken to the cells and then cleaving the substrate that's accumulated in the cells. Some mutations are so-called amenable, so they can react to a chaperone. The chaperone we have approved is migalastat, and migalastat is actually protecting the misfolded enzyme in those amenable mutations from the degradation in endoplasmic reticulum. The misfolded enzyme then gets to the lysosome, and migalastat is actually detaching from it, allowing the enzyme to work and to degrade the stored substrate in the lysosome. What we do in our center, we are always considering the need for therapy, because either the infusion therapy or the oral therapy is representing a burden to the patient, and we should be sure that we are treating a clinically relevant disease. On the other hand, we are also trying to treat patients as soon as possible, because it seems that from clinical data, from registries, it seems that the preventative approach is the best one to stop the progression of the disease. So whenever the first clinically relevant symptom appears, we are trying to set the therapy on. As already mentioned, we are evaluating our patients in a complexity of signs and symptoms of the disease, and we are balancing between the need of therapy and the burden of the disease. So we should really consider how important is the involvement that's related to Fabry disease. So the clinically affected patients are certainly the easiest scenario we can have, because we know that there is a sign or symptom or organ change that's associated to the disease. Especially in classically affected males, it's relatively easy. And females, sometimes it needs a lot of investigative approach to those patients. We need to have evidence from different examinations to be sure that we are really looking at some symptoms and signs associated with Fabry disease. And our target is to prevent irreversible changes. Irreversible changes are, for example, at the level of the kidney, the progression of fibrosis. Whenever you are losing glomeruli due to fibrotic changes, they will never recover. The same happens at the level of the heart. There are fibrotic changes classically distributed in posterolateral wall of the cardiac disease muscle, and whenever they appear, those patients are no more responsive to the therapy the way we would like to see them respond. And of course, we are assessing our patients from the point of view of the quality of life, because the therapy itself, the specific therapy, is not the only option we can offer to our patients. There are many measures that can be taken, for example, at the level of the heart, including pharmacotherapy, including implantation of defibrillators or pacemakers, and we can find similar scenarios in other organ involvements. And of course, it's important to assess life expectancy. Fabry patients may have other diseases. They may have shortened life expectancy due to other diseases. So we should always balance between what we can achieve with the therapy and what is expected because the patient suffers from other illnesses. The difficult scenarios, however, are very frequent. We are not sure that later onset variants are developing the disease so early. So we have sometimes to start our journey a very, very long time before the first clinical manifestation to prevent it. The same scenario applies to females. And in many countries, we are confronted with the possibility that the healthcare payers are opposing to the early therapy, which is the most effective one. So sometimes the cost effectiveness is playing an important role in the decision-making process. And there are, of course, a lot of uncertainties in spite of having more than 20 years of experience. So to sum it up, we have easy scenarios. So classical phenotypes, males with known classical mutations, low alpha-galactosidase A activity, high lyso-Gb3 as a biomarker, and then we should start the treatment as soon as possible. Patients with later onset phenotype and females, we should really be cautious and we should seek for the earliest manifestation possible, but then no delays should be happening again, and those patients should be treated as soon as possible. But on the other hand, there are patients when we are doubting about the pathogenicity of mutations. Patients usually have high residual alpha-galactosidase A activity. They may have borderline or even normal lyso-Gb3, and then we should really investigate the organ involvement in detail, sometimes having access to biopsies and then deciding on whether this patient should be treated or not. In all scenarios, the target is preventative approach, early therapy, and prevention of irreversible changes.
Hello, my name is Eric Wallace, and I'm a practicing nephrologist at the University of Alabama at Birmingham. I'm also a professor of medicine and direct the Rare Genetic Kidney Disease Clinic, which has a specific focus on Fabry disease. Thank you for joining me today in this Touch Expert opinion. We're going to take a closer look at the long-term management of Fabry disease and how we clinicians can support patients and caregivers as they continue their treatment journey. So that's an important question that our patients are going to ask frequently. And what they're really asking is what is known about the safety and what is known about the efficacy of these interventions. From a safety perspective, it's important to let them know that on our original ERTs, which were approved in 2001 and 2003, respectively, we have over 20 years of safety data on these drugs. So we do know quite a bit about the safety. Chaperone therapy, we have recently published studies based on patients who had been on the drug for around 9 years. And now we have patients who have been on 10, 11 years. Finally, for the newest drug, which is pegunigalsidase alpha, although this only got approved last year, we have patients who have been on these drugs for 6 years. So we do have a lot of cumulative data as far as the safety of these drugs. With the most important things that we need to tell people on both of them from a safety perspective is from enzyme replacement therapy. We need to understand that patients can develop antibodies to these drugs and they can develop infusion-related reactions, but we have ways to treat those. So that's important to let the patient know. For the chaperone therapy, one of the most important things to let them know is about the headache. So it's important to let people know what they might experience up front. And so patients can get a headache with the chaperone therapy, but as long as they keep on the therapy, this headache tends to get better, and very few patients actually discontinue therapy because of the headache. So these are the safety things that we need to let our patients know about these drugs. From an efficacy perspective, patients want to know, is this going to make me feel better? So from a feel better perspective, most of our patients experience pain in their hands and feet, as well as significant GI symptoms. And we have studies on these drugs, specifically looking at quality of life, pain, etc., that have shown an improvement in these symptoms. But everybody's a little bit different. So in some patients, they will have significant improvements. In others, the improvements won't be as noted. One of the things that we do know that the earlier we start therapy, the better you tend to do. So by the time you have severe pain in your hands and feet, significant kidney disease, significant cardiac disease, the therapy may not be as effective. It will still be effective, but not as effective as if we started at a very early age, ideally prior to the onset of severe symptomatology. When we talk about kidney disease, so when we talk about things that patients don't necessarily experience until the function is really bad, we start talking about the kidney, right? The kidney is a very important organ in Fabry disease. And all of these therapies now have evidence on the improvement in the stability of kidney function after taking them. So once again, agalsidase beta, pegunigalsidase alpha, and chaperone therapy have all had studies, both short-term and long-term, on the stabilizing the decline in kidney function. As far as cardiac function, I think most Fabry experts will agree that we have an unmet need in cardiac disease. So these therapies have been shown to improve the size of the heart. But despite improving the size of the heart, we do tend to get progression of heart disease, of the increasing the left ventricular mass size over time, development of arrhythmias, et cetera. So just because we are on therapy, we can't not monitor the patient. We need to understand that there's other things that can be adjunctive to therapies. But heart is one of them. And lastly, the brain, right? So the brain has two main manifestations of Fabry disease. Number one is strokes, which the studies have shown specifically in chaperone therapies and in the original ERTs that there is a reduction in the risk of stroke. But the development of white matter disease in the brain tends to progress. So that is usually what we need to tell patients about the long-term evidence of these therapies, and we need to monitor to make sure that the patient is getting the benefits that we think they should. Once again, a great question, and one that's frequently asked by patients and providers. The big thing is, the first thing is just how are you doing, right? I mean, an overall well-being is important to monitor with patients. When we talk about monitoring patients on any therapy, the most important thing is to start with a baseline. So you can't monitor something unless you know what you start with. And the typical things we monitor are heart, kidney, and other symptoms, and the brain. But brain is a little bit harder to monitor. So when we talk about monitoring the kidney, patients on enzyme replacement therapy or chaperone therapy should have a renal function panel with assessment of their estimated GFR at least once a year. And in many of our treated patients, we actually go to twice a year, so once every 6 months. It's important to monitor proteinuria because as the protein increases, there are other medications that we can use, such as ACE inhibitors and angiotensin receptor blockers, to actually reduce the proteinuria. That can slow the progression of kidney disease in these patients. For monitoring of the heart, typically what we do is an echocardiogram or a cardiac MRI if you have access to cardiac MRIs. And in males or females, you try and do these at least once every 1 to 2 years to monitor for the progression of the size of the heart. Is there progression of diastolic dysfunction or the relaxation of the heart? And is there development of late gadolinium enhancements in the posterior ventricular wall? Sometimes cardiac MRIs can be a little bit harder to come by, so echoes are good. They're just not as good as cardiac MRI, so we like to do those. So that measures the structure of the heart. Now, the electrical system of the heart can also be affected, so we typically do Holter monitors on our patients at least once a year or once every 2 years, specifically looking for the development of Brady arrhythmias, which in our experience is more common than the malignant ventricular arrhythmias, to determine when do we need to start putting in pacemakers and AICDs in this patient population. The other symptoms, it's really just asking them, how is their neuropathy? We need to ask, how is their neuropathy, and do they need adjunctive medicines to help? We ask, how is their GI symptoms? Because there are other adjunctive medicines other than the Fabry-specific medicines that we can use to treat that. For brain, we ask about we do a baseline brain MRI to look for white matter disease. This is important because if the patient develops a stroke in the future, we need to know what was already there to compare new brain imaging to what is current. Other symptoms we monitor is tinnitus, dizziness. Patients will frequently get Raynaud syndromes and chilblains on their feet, etc. So we need to monitor all of that. And finally, we need to monitor adherence to therapy, and are they having any reactions to therapy? Adherence to therapy in Fabry is of the utmost importance to make sure that our patients get the full benefit of the therapy. Part of our jobs as clinicians is to make sure that the patients tolerate the therapy. When we talk about enzyme replacement therapy, one of the biggest reasons that patients discontinue therapy is infusion-related reactions. So infusion-related reactions are actually not uncommon and typically present themselves in males more commonly than females, but happen around the third to sixth infusion in naive patients. When this occurs, we need to be able to treat it. So typically patients will have shaking, chills, can develop fevers and pain. So how do you treat those? Well, the first thing, we need to be able to prescribe acetaminophen, diphenhydramine. We also can treat these with steroids such as methylprednisolone. Other things to do are other H2 blockers and up to and including mast cell stabilizers to actually help with these therapies. Finally, one of the newest enzyme replacement therapies, pegunigalsidase alpha, one of the studies of the BALANCE trial actually showed that there was an improved tolerability with reduced infusion-related reactions. So in patients who are really having trouble, despite all of these pre-meds or have a huge burden of pre-medications to tolerate therapy, sometimes it may be worth looking at other options such as pegunigalsidase alpha. For chaperone therapy, one of the most important things is making sure we understand about the headache, and we tell patients early on that you may experience headache within the first 6 weeks of taking the medication, and it's important to keep taking that medication because the headaches will go away and tolerability will improve. Other things about taking chaperone therapy is making sure that patients understand that you can't take it within 2 hours of food or caffeine because that may change the pharmacokinetics of the medication. Finally, one of the biggest issues that we have with adherence ends up being the transition from childhood to adulthood. So any disease state that starts in childhood and transitions to adulthood is going to be lifelong. It's hard to be compliant on medication or adherent on medication for that long. But one of the biggest times that we lose patients to adherence is actually during that time period, around 18 to 25, when people are undergoing that transition where parents were supervising the administration of medicine to now they are really on their own and taking control. And we need to be able to support our patients through that. But adherence is of the utmost importance from the start of this disease to the finish, because that is what all of our outcomes are based on, is patients actually adhering to therapy. But it's our job to make sure that the patient tolerates the therapy well.
Hi, my name is Bill Wilcox. I'm a clinical biochemical and molecular geneticist in the Division of Medical Genetics in the Department of Human Genetics at Emory University School of Medicine down here in Atlanta, Georgia, in the United States. Thank you for joining me today. We're going to take a look at emerging therapies and the importance of interdisciplinary collaboration to individualized care, alongside with what's on the horizon for the management of Fabry disease in the future. Patients with anything but mild early disease detected in childhood have a lot of unmet needs. They are not being that well treated. Most of them are on enzyme replacement. A few are on oral chaperone therapy, those with very specific mutations, but they continue to have persistent symptoms, and the older patients have a progressive organ disease that no matter what therapy we've tried, it doesn't seem to stop it right now, just slows it down. There are a number of new therapies in Fabry disease. One that just got approved is peg-unigase alpha. It is a pegylated enzyme replacement therapy that's dimerized and maybe a little less immunogenic, although I've seen patient have reaction on the first infusion. So it's not for everybody. There's two different substrate reduction inhibitors. These inhibit the synthesis of glucocerebroside, which is the precursor for GL3 and other glycolipids. And one of those trials, the lucerastat trial, failed its endpoint of pain improvement. And venglustat is currently in clinical trials for cardiac and for pain/GI symptoms. There's also a moss plant or fungus-derived alpha-galactosidase that has a mannose terminal group that is maybe not the best way to go, because that's mostly going to target macrophages as opposed to typical enzyme replacement that tackles the mannose 6-phosphate receptors, the way to get into the cell. Patients, as they age, acquire more problems if they're not treated, and some of them acquire those problems even if they are, because we're starting them too late to begin with. And that includes pain that may need pain management, hypertrophic cardiomyopathy with cardiac conduction defects that are at risk for fatal arrhythmias, and that needs to be managed by a cardiologist. They develop chronic nephropathy, and that needs a nephrologist to help manage that. Some of them have gastrointestinal problems that are significant enough that they need to see a gastroenterologist, make sure they don't have something else that we can address. We've had people that had inflammatory bowel disease at the same time. If they can have strokes and TIAs, and may need to see a neurologist. And then we have a lot of mental health problems with depression and anxiety and so on that have to be addressed. So we're, as the Fabry experts, for kind of the central hub for evaluating the patient and deciding what kind of referrals may need to be made. Sometimes we can do that within our own health system, but often these patients are scattered through the state, and they're not going to drive 4 or 5 hours to get all their care for everything. They will for us, but not for everything. Telemedicine helps some, but you need to do exams as well. And some of us, like us, as old people, we don't like telemedicine too much. So they need care, and they need care by people who understand the disease. That's not always possible. It's possible that the center, the geneticist or nephrologist or cardiologist, depending on where you are, is the center for Fabry disease, and we can help advise the other specialists on things they need to look out for. There's fortunately some guidelines on stuff to look out for and how to manage it. The cardiac is probably the one that I deal with the most because of patients that have atrial fibrillation and get put on amiodarone, which inhibits enzyme replacement therapy function. And what they really end up needing is an ablation and a pacer. And they have decreased cardiac output per minute. So even though their ejection fraction is good, they're pretty impaired. So talking to the cardiologist is an important part of what we do. They sometimes don't want to listen, but we do our best. So enzyme replacement therapy, is only able to address some of the disease problems. It doesn't penetrate some cell types very well. It doesn't get into the brain at all. And it requires an IV infusion, and people who have no cross-reacting immunologic material make antibodies to the drug, and that can inhibit its ability to do its job. We may do better switching them to a different ERT like peg-unigalsidase. They may tolerize, they may drop their antibody titer, or they may just have decreased kinds of infusion reactions. We've had that experience, even though they're still showing signs of slow progression of their disease. At least they're not having bad infusion reactions. The oral chaperones only work for very specific mutations, and you really got to follow them, not just rely on what some table tells you it's amenable, but really follow how well they're doing in terms of their biomarkers and so on. We've seen people who have a good response in the test tube with their mutation, but don't respond the same as they do in a live patient. So it depends on what the particular mutation is. So we use the oral chaperones, and we use both of the ERTs that are approved in the U.S. And have experience with those. I don't have any particular preference for starting someone on the new ERT versus the old one. And if someone's doing well on what they're on, I'm not going to touch it and pull them back into an infusion center just to make sure they don't have any reactions. They're all at home, and they can do that after 6 to 12 months without reactions. Women can do it even sooner because they don't tend to make antibodies or have the kinds of reactions that the men do. So I think that's our current therapies, and then we're hoping that either the oral substrate inhibition will work like it does for Gaucher and cut down on how much substrate the enzyme has to deal with. Although if you have no enzyme activity, it's hard to understand how you're going to get rid of what you've got stored. Or gene therapy, where you're delivering enzyme to the body, at least not to the brain. And you're doing it all the time. The substrate reduction can treat the brain. The oral chaperone can treat the brain. So there's a number of gene therapy trials that are going on. There's one that is the most advanced that's been showing some promising results with increased enzyme activity that's persistent, and the patients have gone off their need for enzyme replacement therapy, and they're having improved symptoms, increased sweating, and they're more energy. So I'm hopeful that that's going to pan out in the long run. It's, they have to be hospitalized for a day to get these therapies. It's a virally coded delivery mechanism that induces a intrinsic or immune response. So it makes you get fever and chills and can even drop your blood pressure, as we've found. So it's something you have to be experienced doing. And I'm doing 2 of these trials. There's one of them that's just getting started up that's a different coat, viral coat. They're all adeno-associated viruses. And then there's one that had to be put on hold that may start up again with different kinds of pre-medications because patients developed atypical hemolytic uremic syndrome, which is a serious complication that's been seen in some gene therapies. And requires specific therapy if it occurs. So I'm hoping that one of these is going to pan out, one or more. Now, one of the limitations of these is that they may have antibodies to the capsid protein and then that cannot receive that. And it remains to be seen whether people with high titer antibodies to the enzyme can get these gene therapies either.